Good evening to all. I'm thrilled to welcome you all for today's informative webinar on systematic approach to fetal anomaly scan, 18 to 22 weeks. I'm Vijay, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for the day, Dr. Raisa Samuel. Dr. Raisa, an accomplished medical professional, holds an MBBS, DGO, and MS in obstetrics and gynecology from the prestigious college CMC Vellore. She has further specialized with a post-graduation diploma in family medicine from the same institution, reinforcing her commitment to providing holistic and comprehensive women's health care. Dr. Raisa's expertise in obstetrics and gynecology is well supported by her significant contributions to medical research. Dr. Raisa's dedication to both clinical practice and academic research underscores her role as a key figure in advancing obstetric and gynecological care in India. Over to you, Doctor. Doctor, you are mute actually. You can unmute now. You can unmute. Yeah.
Yeah. So today's topic is systematic approach to fetal anomaly scan, which is done usually from 18 to 22 weeks. So this is out of all the antenatal scan, this is the most difficult scan to perform, and also it is the most important scan that one should have. So if you ask a patient, especially in a rural setting or patients who cannot afford antenatal scan, one scan that it should be done in the whole of pregnancy would be this scan. At least they should have had this anomaly scan. So what all do you see in fetal anomaly scan or the scan which is done around 18 to 22 weeks? You look for the fetal heart rate, fetal morphology scan, and fetal echocardiography and placental localization. Also, other variables are also seen, which we will deal with in detail. So what is mid-trimester scan? What is its importance or the purpose? It's a routine ultrasound performed between the 18 and 24 weeks of gestation, preferably between 18 to 22 weeks. Primarily, it is for the anatomical evaluation of the fetus. Why is this gestational age important? Optimum time, because normal fetus, where a fetus can be named normal with a good degree of accuracy. So here what happens is around 70% of the major anomalies and 45% of minor anomalies can be detected at this time. So that is why this period of gestation is important to do the anomaly scan. So who should have a mid-trimester fetal ultrasound scan? All pregnant women should be offered a mid-trimester scan as part of their routine pregnancy care. So any woman who come to you, you should tell them from the beginning that this is the scan which you should never miss. So what is the objective of this scan? To provide accurate diagnostic information for optimized antenatal care and best possible outcomes for both mother and fetus. So what are our goals? Confirm the viability if it is already not done. Usually we have a scan in the first trimester and another NT&B scan around 12 to 13 weeks. So if it is not done, then you should confirm the viability in this scan. Determine the gestational age if it is not already precisely done in the first trimester. Identify the number of fetuses and chorionicity, amnionicity in multiple pregnancies. So if it is already not done, then you do it in this scan. Evaluate the fetal biometry and growth, screen for structural anomalies, assess the placental location and amniotic fluid volume, evaluate the cervix, uterus and adnexa if it is feasible. So first you should counsel the patient, discuss the benefits and limitation with the woman or the couple before the scan. The scan is important because in case if there are multiple anomalies, then you should discuss the about termination of pregnancy if it is fatal for the fetus. So that is why this period of gestation is also important. So if you are suspecting any anomalies, you should do it around 18 weeks because up to 20 weeks, the fetus can be terminated. Then if it is beyond 24 weeks, you have to have 2 gynecologists. So because of the MTP Act, So it is better you discuss with the patient and counsel them to have a scan around 18 weeks. So what are, this is one of the scan which needs high skill also. The person who is performing the scan should be trained and should have had done some training, especially in the anomaly scans. All those who perform, radiologists who perform the normal scan may not be able to do an anomaly scan. It has to be highly trained person and who's regularly performing fetal ultrasound scans, but who's continuing in medical, who's developing their skills through continuing medical education, appropriate referral patterns for abnormal findings. So if they suspect any abnormal findings, they should refer them to fetal medicine specialist or to a fetal cardiologist, or if, depending on the specific findings. So routinely, and also who routinely undertakes quality assurance. So this should be the operator qualification, the one who's performing the ultrasound. Equipment, as we know, should be a grayscale, real-time grayscale ultrasound capabilities, trans-abdominal transducers with suitable resolution and penetration. The range is 2 to 9 megahertz. Adjustable acoustic power output controls with output play on the screen. Freeze frame capability, electronic calipers, capacity to print or store the images. Regular maintenance and servicing should be done for the equipment performance. So, cleaning of the equipment and cleaning of protocol should be followed. Color and pulse Doppler are desirable, should preferably be there. And transvaginal probes also are should be there in case if we have to do a transvaginal scan for placental localization or cervical length along with the anomaly scan. And they should adhere to the safety protocols. Report should be given, the result of the scan should be documented and communicated appropriately, and the copies of the report and images should be stored for future reference. So it should be given as a printed copy or a written copy, and it should be explained also to the patient properly. So second trimester ultrasound, what all do we see in the fetus? Estimation of gestational age, fetal biometry, number of gestation, evaluation of multiple gestation, amnionicity and chorionicity, amniotic fluid, placental localization. Also, it could be done adjunct to any prenatal diagnostic procedures like amniocentesis, chorionic villus sampling, or fetal blood sampling. Transvaginal ultrasound is usually performed for the cervical insufficiency to see the cervical length and for placental localization. So if the first trimester ultrasound is the best for gestational age calculation, but if the patient did not have a scan in the first trimester and is coming to you in the second trimester, then you, if you need to calculate the dates, then you should go by the biphysical, you should go by the biparietal diameter, that is BPD, 14 to 20 weeks. But then you have to keep in mind that it could be around plus or minus 7 to 2 days difference will be there. So if it is 21 to 30 weeks, then there is a 2 weeks discrepancy, plus or minus 2 weeks. If it is more than 30 weeks, plus or minus 21 to 28 days difference. So best is first trimester ultrasound, where the difference is only, you take CRL and the difference is only 5 days, plus or minus 5 days. So there is a standardized approach to the ultrasound, how you do the ultrasound. You cannot just start doing the, keep the probe and then first see the placenta. There is a systematic way how you do the ultrasound. So first step is you look at the fetal presentation and lie. Mostly when you see an ultrasound report also, you see the report in this specific order. So it should ideally be in this order. So first you comment on the fetal presentation and lie, that is whether it's cephalic, breech, transverse or oblique. Usually at this gestation, it would be a variable lie, that is the fetus keep changing the position. So most often you see in the report that it's variable lie, that it doesn't stay in a specific presentation. And then you look for whether it's longitudinal, transverse or oblique. Fetal cardiac activity, confirm that presence of fetal heart rate and what is the rate. You have to measure the fetal heart rate also, and M mode for documentation. Put it in the M mode for documentation. Number of fetuses, you see whether it is single, twins or multiple. In multiple pregnancy, then chorionicity and amnionicity are crucial. Usually it is done in the first trimester scan. If it is not done in first trimester scan, you can do it in the second trimester scan. Placental localization and position, whether placenta is anterior, posterior, fundal, or if it's lateral. What is its relationship to the internal os? If it is far away from the internal os, we usually say if it is low-lying, if it is covering in placenta previa. If it is away, how many centimeter is it away? It should be at least 2.5 centimeter away from the internal os to call it not low-lying. So estimation of the amniotic fluid is the next step. It's a subjective assessment where you qualitatively measure the amniotic fluid. You look at the four, we will in detail see how it is done. So deepest vertical pocket, DVP, and with the all four pockets, you will calculate the amniotic fluid index. That has to be mentioned. Next is the fetal biometric measurements, that is biparietal diameter, head circumference, abdominal circumference, and femur length. This all four measurements will give you the estimated fetal weight. So if gestational age established by earlier accurate scan, then do not redate based on the mid-trimester scan. As I said, if it is already dating scan is done, then you should never redate it with this scan. So first we will see fetal biometry and well-being, how it is done. The biparietal diameter, head circumference, abdominal circumference, and fetal femur length can be measured routinely for the assessment of fetal size. So if the fetus has not been dated previously, then you use this for dating. Biparietal diameter is used. How do we measure the biparietal diameter? It is the outer to outer placement of calipers is preferable when measuring biparietal diameter. This is how the biparietal, so you take the, look at the fetal head and then following landmarks should be, ensure that the following landmarks is acquired in the imaging plane. So you have to keep your transducer at 90 degrees inclination to the midline echoes, but slight variation is permitted. So the transverse view of the fetal head should be at the level of the thalami. So this is the thalami, you can see. So this is the transverse view of the thalami, and from here this outer to outer is measured as the biparietal diameter. So here you can see it is 4.78 centimeter, which is corresponding to 20 weeks and 3 days of gestation. So as soon as you measure, place your calipers here, one at this point and other at this point, you will get this measurement and automatically the system will calculate the gestational age. So symmetrical appearance of both hemispheres. So you have to make sure that the level at which you are taking should be correct. So midline echo interrupted anteriorly only by the cavum septi pellucidum, and cerebellum should not be visible. So this is the level at which these two hemispheres, you can see they are equal. The thalami is here and you cannot see the ventricles. Cerebellum is also not seen, and this is the level at which you have to take your measurement. Now next is this also again a picture of the biparietal diameter, how we are measuring outer to outer. This is the perfect plane at which you have to take the measurements. Next is head circumference. Head circumference can either be measured using the ellipse approach or it can be derived from BPD and OFD. Outer to outer placement of calipers are preferable when measuring head circumference. Again, same anatomy, the same anatomical landmarks as those of BPD should be used. So the cut section, this should be the same. This will be the same. Now you are placing the use the your calipers and then place it in the elliptical as an ellipse. You go from one end to the other end and form an ellipse. So once you form this ellipse, automatically it will measure 17.80 centimeters, you can see here, and that is corresponding to 21 weeks and 1 day. So this you just have to place your calipers in the right position and your probe should be there in the correct position. Press freeze and then you take the measurements. So here also you can see that this is the elliptical way how we measure the head circumference. This is also head circumference. Abdominal circumference, how do you measure? For the measurement of abdominal circumference, the transverse section of the fetal abdomen should be as circular as possible and the fetal spine should be preferably in the 3 or 9 o'clock position. Abdominal circumference can either be measured using the ellipse approach or derived from the anteroposterior and transverse abdominal diameters. So the anatomy at this level, the anatomical landmarks that ensure optimal acquisition of this plane is for the measurement of abdominal circumference is transverse section of the fetal abdomen as circular as possible. It is little difficult to get this abdominal circumference measurement, that transverse section, but these are the key features you have to see where you have to place your transducer. And if you get all this perfectly, then your abdominal circumference will also measure correct. So umbilical vein at the level of the portal sinus, stomach should be visible and kidneys should not be visible. So here you can see the stomach bubble. This is the liver and this is the portal sinus. So you can see that the umbilical vein is here. This is the liver and this is the stomach bubble. So this, and you can see that this is almost a perfect circle. So here you can when you place your caliper in an elliptical fashion, elliptical way, you can see that this is measuring 15.40 centimeter and the gestational age is corresponding to 20 weeks and 2 days. So in the later growth scans and all, abdominal circumference is very important because that will give you, we go by the abdominal circumference to diagnose fetal growth restriction. So if the baby is growth restricted, then if the abdominal, then we look at if the estimated fetal weight is small, then we look at the abdominal circumference to see whether the abdominal circumference is actually not corresponding or not. If it's not corresponding, if it is lower, then we will say that it is a fetal growth restricted fetus. So here you can see this is the stomach bubble. Here the ribs are present here on either side. This is the aorta and this is the vein. The last measurement that we need to take is the femur length. The femur length is imaged with both ends of the ossified diaphysis visible. The longest axis of the ossified diaphysis is measured. The same technique as that used to establish the reference chart should be used with regard to the angle between the femur and the insonating ultrasound beam. An angle of insonation, usually you can keep the transducer at the angle of between 45 and 90 degrees is typical. There are technical improvements in modern ultrasound machines have reduced the beam width, which has affected fetal measurements in the lateral direction. This has clinical implications and recent measurement charts should be used. Do not use the older one. Using older ones may lead to an overestimation of femur length. So here you can see how the femur is measured, femur length. So you any right or left femur you can measure. So this is from the one ossification to the other ossification. You have to measure this length in a straight line. And once you measure this, it will give you 3.64 centimeter and that will give you the corresponding gestational age 21 plus 6. So caliper placement, each caliper is placed at the ends of the ossified diaphysis without including the distal femoral epiphysis if it is visible. So this epiphysis you should not take. This is here is the epiphysis. You have to take the ossified diaphysis only from this end till this end. This measurement should exclude the triangular spur artifacts that can extend the diaphysis length falsely. So here another clear picture from this end till this end. Here, this triangular spur you should not take. This part. Now, estimated fetal weight, the Hadlock 3 formula is used, which is head circumference, abdominal circumference, and femur length, to be the most stable mathematically and is recommended in most clinical scenarios. The deviation of the estimated fetal size from the expected mean for the gestational age should be expressed as centile and chosen reference. So there are charts, you get the growth chart on the WHO growth chart, you plot the estimated fetal weight and then see how much it is, if it is normal or if it is how much centile less. So that is the, or the Z-score, see how much it is falling below or above the recommended growth chart. So fetal biometry charts, which are prescriptive, obtained prospectively, and truly population based and derived from studies with the lowest possible methodological bias should be favored. So the use of Delphi 2016 criteria should be used for definition of fetal growth restriction. That is, if it is less than 5th centile, then it is FGR. Less than 10th centile is FGR. If it is less than 5th centile, then it is severely growth restricted fetus. So once you get all the 3 measurements, that is, this is the head circumference, abdominal circumference, and the femur length, the chart will give you, they will plot it, automatically the machine, ultrasound machine will give you all the measurements and the estimated fetal weight. This is a term patients and it is coming, this is around 37 plus 2 weeks. Similarly, 20 weeks or 18 weeks, the estimated fetal weight will be given in grams. Next important thing to measure is amniotic fluid volume assessment. AFI may be preferable in assessing polyhydramnios. If you are measuring oligohydramnios, then you have to use the deep vertical pocket. That is a single deep vertical pocket which is free of any cord, without any cord or without anything. One deep vertical pocket should be measured. The amount of amniotic fluid should be evaluated either subjectively, you should define it as normal or abnormal, or if it is reduced or increased, or semi-quantitatively by measuring the deep vertical pocket, that is, it is given as centimeter, and by calculating all the 4 quadrants, it will give you the amniotic fluid index. Again, it is represented as in centimeters. So here you can see this is quadrant 1, quadrant 2, quadrant 3, quadrant 4. All 4 quadrants of the from the uterus you have to measure, and you should make sure that it is a perpendicular. You have to place the probe transducer perpendicular and measure the from the caliper should be placed perpendicular from top to bottom, and you should make sure that there is nothing inside, like there should not be any cord or any fetal part, or nothing should be there in the place where you are measuring. Now all 4, or if you once you measure all the 4 quadrants, automatically again here you can see that quadrant 1 is measuring 5.56 centimeters, quadrant 2 is 8.49 centimeters, quadrant 3 is 6 centimeters, and quadrant 4 is. So the total it will add up and give you 29.08 centimeters is the AFI. Now, if you take single deepest pocket, in this, which is the deepest pocket, that is 8.49 is the single deepest pocket. So you can write single deepest pocket is this much. Now, deep vertical pocket, or the largest vertical pocket free of umbilical cord or fetal parts, is measured. If it is less than 2 centimeters, is considered as decreased amniotic fluid volume or oligohydramnios. If it is 2 to 8, then it is normal. If it is more than 8 centimeter, then you say polyhydramnios or increased amniotic fluid volume. Reference values for gestational age can also be used. Each gestational age, during mid-trimester, it will be high, and towards the end of the last trimester, third trimester, the amniotic fluid volume decreases. So this is a single deep vertical pocket. Here it is 14 centimeter is this pocket. You can appreciate that there is no fetal pole, or there is no cord, or nothing is there. So this is a correct measurement. So what are the recommendations for performing this semi-quantitative assessment? Hold the ultrasound transducer perpendicular to the maternal position. Identify clear boundaries of the upper and lower edges of the pocket. Measure the largest unobstructed amniotic fluid pocket. Use color Doppler for areas where the umbilical cord is not visualized. So if you have a doubt that whether cord is present in there, just put the color Doppler and see. So if the color Doppler is showing red or blue, this thing, that means cord is present. So you cannot take that pocket. Now going on to amniotic membranes can also be assessed. So from 16 weeks onwards, the amnion and chorion are usually fused. Amniotic sheaths are, sometimes you see amniotic sheaths, which are benign findings, should to be distinguished from amniotic bands. If amniotic bands are present, it could be associated with fetal deformities. Next, you look at the fetal movements. Normal fetuses typically are in one neutral position and show regular position. So they are, they will move their limbs, they move their hands, legs. So you have to look for the fetal movements. Temporary absence or reduction of movement during the scan should not be considered as a risk factor. So if if the fetus is not moving for quite a long time, then you have to assess it. For a short duration, if the fetus is not moving, then no, it's not a risk factor. Abnormal position or unusually restricted or persistently absent fetal movements may suggest abnormal fetal conditions such as arthrogryposis and should prompt a request for referral. The biophysical profile is not considered part of the routine mid-trimester scan. When we do the BPP, where the fetal movements, fetal tone, fetal breathing are all measured in biophysical profile, it is usually not done in from this 18 to 22 weeks. It's usually done after 32 weeks or 28 weeks at least. Umbilical cord, although formal assessment of the umbilical cord is not part of this scan, it is, if it is marginal or velamentous cord insertion is visualized, you have to report it. When there is a single umbilical artery also identified in the mid-trimester scan, that also should be mentioned, but you should not cause anxiety to the patients by saying that it's a single umbilical artery. Most of the time, single umbilical artery as such, if you find as an isolated finding, it does not have any complication. It is not associated with any complication. Sometimes you see single umbilical arteries associated with fetal growth restriction and other structural defects. So you have to do a detailed anomaly scan, should be very detailedly done to rule out other anomalies. And also you have to counsel the patient that there is a possibility of fetal growth restriction. So they should be advised a serial growth scan from 28 weeks onwards. 28 weeks, 32 weeks, 36 weeks, they should have a serial growth scan done. So this is the umbilical artery. This is how it looks. Umbilical cord, and once you put the Doppler, you can see the vessels, the umbilical artery and the vein. So the umbilical cord insertion is usually at the center of the placenta. That is normal. In around 80% of cases, it is like that. In 12%, it could be paracentral, and around 5 to 8% of cases, it could be marginal also. Velamentous insertion occurs in about 1% of cases, and is when the insertion of the umbilical vessels is directly within the amniotic membrane instead of the placenta. That is called velamentous insertion of the umbilical cord. So if usually if there is velamentous cord insertion, they could be associated with vasa previa and fetal growth restriction. So this should be carefully ruled out. When marginal or developmental insertion is visualized, it should be reported. Formal assessment is not usually done of cord insertion and placenta is not routinely done with mid-trimester scan. But in case if you are seen these findings, you have to report it. Number of vessels, single umbilical artery is a result of obliteration or atrophy of one of the arteries. Most commonly, it is the left artery which gets obliterated. It is more frequent in twin pregnancies. Diagnosis is made by direct visualization of the umbilical cord, or you track the umbilical arteries around the fetal bladder with color Doppler. So it could be associated with congenital anomalies at fetal growth restriction, although it does not constitute an anomaly per se. Sometimes it will be just an isolated finding. So you should not cause anxiety to the patients, and you have to discuss to the patient about the complication also. So this is the normally there is 2 artery and 1 vein. So you can see the umbilical vein and 2 arteries. So if one of the artery is absent, then there will be single umbilical artery and 1 single vein. So here you can see single umbilical artery. This is the artery and this is the vein. So here urinary bladder is here. So here they are tracing it with the color Doppler to see the umbilical artery and the vein. What is coiling? Coiling describes the spiral course of the umbilical arteries in the cord. It can be increased or reduced umbilical cord coiling, but it has not found to have any significance. But if you have seen these findings, you have to mention it. Doppler per se is not routinely done during the this anomaly scan, but if you are suspecting an early onset FGR or something like that, then you should perform a Doppler scan. And uterine and umbilical artery Dopplers are evaluated. Routinely do not do Doppler for low risk patients. Color flow Doppler imaging is encouraged and can assist the examination of the fetal heart and the cord vessels and in determination of the amount of amniotic fluid in the pregnant woman. So this is the Doppler, umbilical artery Doppler. How do you place it in the umbilical cord? You trace the vessel, umbilical artery, and then place the press the color flow, and then you trace the graph. This will give you the umbilical artery Doppler, S/D ratio, PI, and resistance index. This is middle cerebral artery Doppler. Multiple gestation chorionicity should be determined in the first trimester if possible. So if this is second trimester scan is not the ideal time to determine the chorionicity. In case if first trimester's ultrasound was not done, and it is not possible to identify 2 separate placenta and fetal gender in the same, the pregnancy should be considered as monochorionic, because monochoric twins are found to have more complications. In case if you are not sure if it is dichorionic or monochorionic, keep it as monochorionic and counsel the patients and look for complications as the pregnancy continues. So this is what you will see in a twin pregnancy for lambda sign and T sign. Lambda sign is dichorionic, diamniotic. This is monochorionic, diamniotic. So you differentiate check the chorionicity by this lambda sign and T sign. This should be ideally done in the first trimester. Now going on to the main thing, that is the anatomical survey. So this is called, either this scan is called morphology scan, or it is also called as anomaly scan, where you do the detailed anatomical survey of the fetus. So basically you are doing the head-to-toe examination, head-to-toe assessment of the fetus. All the organs are developed. And now you have to look for any structural anomalies. So from when you say head to toe, you have to go in the same order as head to toe itself. So in the head, you look for the intact cranium. You look at the shape of the skull, head shape, the cranium, whether there is any defect or not. Cavum septi pellucidum is seen whether it is normal in appearance or not. Choroid plexus is looked at. Midline forks is seen whether it's normal in appearance. Thalami is looked. Lateral cerebral ventricles, whether they are normal or not. Cerebellum, whether they are normal or not. Ventricles is very important because ventriculomegaly can be present. Hydrocephalus will be present. So that ventricle has to be assessed. Cisterna magna, whether it is present or not. Then you look at the nuchal fold, whether it is normal or normal in appearance. So head, you have to see all these structures has to be carefully examined. And if all the structures are normal, then you can say head normal. Now going on to the face, both the orbits and bulbi, whether it is present. Mid-sagittal facial profile, whether it is normal in appearance. Nasal bone, whether it is normal in appearance. Upper lip, whether it is intact. Here again, the importance is nasal bone. You should have ideally seen it in the NT&B scan that is done at 12 to 13 weeks. Upper lip intact, you are looking for any cleft lip, cleft palate. All this can be diagnosed. Cleft lip can be diagnosed in the second trimester in the anomaly scan. So it has to be carefully looked at. Again, you're going to the neck, look for any masses. So cystic hygroma is something, again, all these are diagnosed in the first trimester scan itself. So these, if not done, then has to be look for carefully. Now going to the chest, chest is very important. It has both heart and the lungs. So first you look at the lungs, whether it is shape is normal. Heart, you look at the heart activity is present. Then you look at the 4-chamber view of the heart in normal position. That is left chambers on the left side. So you see where the heart is positioned, where the heart is in the left side, is if there is any dextrocardia or not. Aortic and pulmonary outflow tracts are assessed, relative size and their relationship. Normal LVOT view, left ventricular outflow tract view, 3-vessel view or 3 vessels and trachea view, whether that is normal. No evidence of any diaphragmatic hernia. All this has to be seen. Going to the abdomen, I will show you in detail each structure. Abdomen, you look at the stomach, whether it's normal in position on left side. Bowel, whether it's normal, if it's not dilated or hyperechoic. Gallbladder on the right side. Both kidneys present, if there is any pilectasis or not. Again, this is a common finding that we see dilatation of the pelvic ureteric at the PUJ junction. You can see dilatation. So they say renal pelvic dilatation. Urinary bladder, whether it's normal or in appearance. Cord insertion site into the fetal abdomen, whether it is normal. Skeletal, you look for any spinal defects or any masses. Transverse and sagittal view. Both views you have to see. Arms and hands are present or not. Normal joint position. Legs and feet, if they're present or not. With normal joint position. Then look at the placenta, placental position and relation to cervix, normal. There's no masses or any hemangioma or anything. Umbilical cord, whether it's 3-vessel cord insertion into the placenta if it's normal, and genitalia. Genitalia has to be examined, but you should never mention what is the sex of the fetus. You should say normal genitalia. Genitalia appears normal. Cervix, you look for the cervical length measurement, whether it is normal or not. So head, basic examination of the skull should include the assessment of size, shape, integrity and bone density. The basic examination of brain should include this 2 planes you have to see. Transventricular plane, that is at the level of the ventricles you have to see one plane, and transthalamic plane for assessment of the hemispheres, and an additional axial transcerebellar plane for the assessment of the posterior fossa. Now look at the skull. Four aspects of the fetal skull should be evaluated: the size, the shape, the integrity, and the bone density. All these characteristics can be visualized at the time of the head measurement. That when we do the biparietal diameter itself, you can see all this. So you have to evaluate the anatomical integrity should be evaluated. Size measurements are performed as explained in the biometry section, and the shape, normal shape, has an oval shape without a focal protrusion or defects and is interrupted only by a narrow equilucent sutures. Alteration of shape, sometimes you see lemon shape, strawberry shape, clover leaf shape. All this should be documented and investigated. If you find an alteration in shape, then you have to mention it. So this is an oval shape, normal looking fetal skull. This is an abnormal shape of the fetal skull. So you look for no bony defect should be present. Brain tissue can extrude through the defect. Sometimes you can see there is some defect in the brain and then brain tissues are extruding. For example, of the frontal or occipital bones. Bone density, it should be normal. High skull density manifests as a continuous echogenic structure that is interrupted only by cranial sutures in specific anatomical locations. If there is absence of whiteness or unusually clear visualization of the brain, fetal brain, this should you should think of osteogenesis imperfecta or hypophosphatasia. These anomalies should be thought of if the if you see absence of whiteness or if it's unusually clear. Brain, as I mentioned already, should be at the transventricular and transthalamic planes, and this will help you to as we mentioned all this structures: cavum, lateral ventricles, cavum septi pellucidum, middle phalanx, middle falx, thalami, cerebellum, and cisterna magna. All this will be evaluated once you place your probe in the transducer at these planes. So it should be transventricular and transthalamic planes. And for posterior fossa, you have to keep it at transcerebellar phase. So this is the thalamus. You can see this is the thalamus. This is cavum. So this is the transthalamic plane where you can see the cavum and the thalamus. Here you can see the thalamus. This on both sides is the thalamus and this is the cavum. The front of the fetal skull and this is the back. This is the atrium. This is the ventricular plane. So here you can see the third ventricle. This is the thalamus, hippocampus, cisterna magna is here, cerebellar hemisphere is here. This is the cerebellum. This is the anterior horn. Here is the coronal suture. This one. This is the cerebellum. Here you can see clearly cerebellum on both sides. And this is the cisterna magna. The 18 weeks skull. This is a 20-week skull. 23 weeks. 27 by 27 weeks you will see, and this is 28 weeks how the brain looks like. Now going on to the face, the basic examination of face should include visualization of the upper lip, presence and position of the orbits or eyes. If possible, you have to assess the fetal profile. Other landmarks are nose, nostrils, palate, maxilla, mandible, tongue, and ear position and the size also should be assessed, but they are not part of the routine examination. You have to, if you are able to see all this, like with experience, you will be able to appreciate more clearly all the structures. So if you are seeing anything abnormal, you should report it. Three-dimensional ultrasound may be useful tool, but nowadays 3D ultrasounds are there for the fetal phase. It is very helpful, especially if you are suspecting any facial anomalies like cleft lip, cleft palate. Cleft lip is clearly seen, but cleft lip palate, if you have to diagnose, you might require a 3D ultrasound. So here is the orbit. You can see clearly the orbit here. This is the face. Here is the nasal bone. This, which is more white in color, that is the face nasal bone. This is the mandible here. This is the maxilla, maxillary sinus, maxilla. Here is the maxillary process. This projection here. This is the orbit. Lens, you can see inside the orbit, you can see the lens. This is the condylar joint. So that is how you assess the fetal face. So here again, you can see the nasal skin. This is the nasal bone, tip of the nose. This is the palate. Here the thalami, midbrain, brainstem, fourth ventricle, medulla oblongata, and this is the nuchal translucency. That is the NT measurement. Going on to the neck, presence of any obvious neck masses should be documented. The neck normally appears as a cylindrical with no protuberances, masses of fluid collection. If there is any obvious neck mass, then you have to mention it, cystic hygroma or any goiter or teratoma, that should be documented. This is the neck. So you can see from the posterior, this is 16 weeks. Here you can see the neck. 18 weeks, here you can see the neck. Here, this is a pseudomembrane, and here you can see there's something protruding here. Going on to the thorax, the basic examination of thorax should include the assessment of its shape, transition to the abdomen, from the neck which goes down to the abdomen, the shape of the ribs, the texture of the lung, when feasible, visualization of the diaphragm. Diaphragm is little difficult to visualize, but if possible, you have to visualize it. Then the shape of the thorax should be regular with a smooth transition to the abdomen. The ribs should have the normal curvature without any deformity. Both lungs should appear homogeneous without evidence of any mediastinal shift or masses. Diaphragmatic interface can often be visualized as a hypoechoic dividing line between the thoracic and abdominal content. For example, between the heart and the stomach or lung and the liver, you can see a hypoechoic dividing line. That is the diaphragmatic interface. That's how you identify the diaphragm. Here you can see this is the ribs. Here, this is the lungs. You can see the ribs here. These are the ribs. This is the lung, the thorax. And this is the liver, stomach bubble. So this area is the thorax. This whole area. This has to be assessed. Here you can see this line. Here is the diaphragm between the liver and the lungs here, and here you can see the stomach between here. Here you will see the diaphragm. This is the ribs. You can see the spine, and clearly you can see the ribs, all the ribs. This is the lungs, the liver. The one line is present here. That is the diaphragm. This is the stomach, portal vein, and the spine. Here you can see the heart. Going on to the heart examination of heart should start with assessment of its situs. First, you have to see whether the heart is in the left side or not, the axis of the heart, and the rhythm. The heart rate, whether it's in the normal rhythm or not. Anatomical examination of heart should include 4-chamber view, the outflow tract view, and 3-vessel view. So 3 views you have to see. Fetal cardiac screening is performed for detection of any congenital heart disease during the mid-trimester. So it's very important to see the fetal heart at this scan. Images should be magnified until the heart fills at least 1/3 of or 1/3 to 1/2 of the ultrasound display screen. So you have to magnify the image to that level to see. The scanning procedure should begin with the 4-chamber view of the fetal heart. A normal regular heart rate is typically 120 to 160 beats per minute. The heart is usually positioned in the left chest as is the fetal stomach if the situs is normal. So left side it's usually present. The normal heart is usually no larger than the 1/3 of the area of the chest and is without pericardial effusion. The heart axis deviates to approximately 45 plus or minus 20 degrees towards the left side of the fetus. Routine cardiac screening should also assess the aortic and pulmonary outflow tracts to detect cardiac malformations beyond those achievable using the 4-chamber view alone. So just by looking at the 4-chamber view, you cannot say that the heart is normal. You have to look at the pulmonary outflow tract and also the aortic view also should be done. So this is how the heart looks in a ultrasound. And you have to see, this is a 4-chamber view. You can see all the 4 chambers, left ventricle, right ventricle, left atrium, right atrium. So this is called the 4-chamber view. And you look at all the foramen ovale, the pulmonary vein, the mitral valve, the tricuspid valve, all has to be assessed in this 4-chamber view. Now, when you go, the other views that you see is here also. Here you can see left ventricle, right ventricle, left atrium, right atrium, and this is the aorta, the descending aorta. You can see here descending aorta, left pulmonary artery, right pulmonary artery, ascending aorta. Here you can see the right ventricle, left ventricle, the left pulmonary artery. Same, you can see when you put the color flow, you can see the blood flow also into the heart. So normal appearing great vessels are approximately equal in size and should cross each other as they exit their respective ventricular chambers. So routine assessment of the cardiac outflow tracts in addition to the 4-chamber increases the screening performance, mainly to look at the anomalies like tetralogy of Fallot, transposition of the great arteries, double outlet right ventricle, and truncus arteriosus communis. So these anomalies can be diagnosed at this outflow by assessing the outflow tracts. The 3-vessel view and closely related 3 vessels and trachea view may improve the detection of outflow tract, aortic arch, and systemic vein anomalies. So here you can see the ductal arch, aortic arch, superior vena cava, and trachea. Here you can see this is the right atrium, right ventricle, pulmonary artery, and aortic. So this is the 3-vessel view. Here you can see right ventricle, left ventricle, and aorta. Here you can see right atrium, right ventricle, and aorta, and right ventricular outflow tract. So in case if you see any anomalies or if you have any doubt if you suspect any anomalies or any septal defect or mitral valve septal defect or any cardiac anomalies, left ventricular hypertrophy or anything that you are suspecting, then you have to advise a fetal echography also, which will enhance the diagnosis. So if there is in the normal anomaly scan, if you are suspecting any cardiac anomalies, fetal echography can also be done. Abdomen, the presence of situs, again same, you have to see where the stomach is placed and the shape of the stomach should be examined. From left to right, the stomach, umbilical vein and gallbladder should be visualized. Assessment of the gallbladder is optimal. Fetal umbilical gallbladder is quite small, so it might be difficult to assess. Fetal umbilical cord insertion site should be examined. Abnormal fluid collection or in or around the bowel should be documented. Increased echogenicity of the bowel equal to that of bone should be prompt referral. So here you can see the stomach and the abdomen. The fetal stomach should be clearly visible in its normal position on the left side and should occupy about 1/3 of the left half of the transverse section of the fetal abdomen used for abdominal circumference measurement. Any abnormality of position or location of the stomach or any significant deviation in size like persistent non-visualization or barely visible stomach or stomach expanding beyond the midline or presence of double bubble sign should be prompt referral should be done. You have to mention that. 3 hypoechoic structures should be identified in the upper fetal abdomen from left to right, that is stomach, umbilical vein and gallbladder. Gallbladder, as I said, it is difficult to see, so if it is not seen, then don't mention it. An abnormal location of any of these structures can be associated with congenital anomalies. If there is a persistent right umbilical vein, if there is heterotaxy, photohepatic shunt, all this should be looked for. The bowel should be contained within the abdomen. The fetal umbilical cord insertion site should be examined for evidence of a ventricle wall defect, such as omphalocele or gastrochisis. Sometimes you see that there is a wall defect and the part of the bowel is protruding outside through the skin. So that is omphalocele or gastrochisis, where the part of the bowel is coming outside. So that can be diagnosed by looking at the abdomen. Abnormal fluid collection in or around the bowel, that is any ascites or enteric or any obvious bowel dilatation seen, should be documented. Increased echogenicity of the bowel should again, if you find that the bowel is looking as echogenic as a bone, then that should also be mentioned. So here you can see the stomach. This is the spine and this is the umbilical vein. So this part of the abdomen should be assessed. Here you can clearly see the gallbladder. This is the stomach, umbilical vein. This is right side, this is left side. So here you can see the stomach. Now going on to the kidneys and bladder, the fetal bladder and both kidneys should be visualized. If either bladder or renal pelvis appears enlarged, then you should do a detailed assessment. Renal pelvis, if it is more than 7 millimeter, it indicates a need for reassessment in the 3rd trimester. Most of the time you would have seen RPD dilated, renal pelvic dilatation. So if it is more than 7 millimeter, you should advise them serial ultrasound and look for the measurement of the renal pelvis. Bladder should not reach the level of umbilical cord insertion. At 18 to 22 weeks, 95th centile for the longitudinal bladder measurement is about 14 and 23 millimeters respectively. So this should be your measurement, ideal measurement. At 18 weeks should be around 14 millimeter and at around 22 weeks should be 23 millimeter. Abnormally enlarged fetal bladder or persistent failure to visualize the bladder should prompt again referral and more detailed assessment. So here you can see the left kidney this is the left kidney, this is the right kidney, and when you see from front, it will be right kidney, left kidney on both sides. Here you can see the left kidney, right kidney. This is the stomach and this is the aorta. When you put color flow, you can see the aorta. These are the renal veins and renal artery. And this is the liver, spleen here, and left kidney, right kidney on either side. Here you can see the left kidney, right kidney. On this, you can see left kidney, right kidney. This is the kidney. You can see the kidney here also clearly. This diagram also, you can see the kidney clearly. And this is the vessel. There is a condition called polycystic kidney disease where there is multiple cystic appearance in the kidney, which can be diagnosed in the level 2 or anomaly ultrasound. So here in this diagram clearly shows there are multiple cystic appearance. This is called polycystic kidney disease. So this is the renal pelvis. So if you measure this, what is the diameter? If it is more than 7 millimeter, then it is significant. If it is less than 7 millimeter, then it is normal. So this diameter has to be measured. So this is a renal pelvic pylectasis. Here you can see the left kidney, and this is the dilated. Now going on to the spine. Going on to the spine. Spine, the basic examination of fetal spine should include transverse and sagittal view. Now, both views has to be taken. Satisfactory examination of fetal spine requires expertise, and you need a meticulous scanning, and it should result a vary dependent upon the fetal position. So here at 18 to 20 weeks, the fetus is quite small and it keeps moving very fast. So it is kind of difficult to, you need the fetus to stay in a stationary position for quite some, for a few minutes at least, to get a satisfactory examination, to do a satisfactory examination. Complete evaluation of the fetal spine in every plane is not part of the basic examination, although transverse and sagittal views, if you are able to see, that is enough. The most frequent severe spinal anomaly is open spina bifida. So neural tube defects should be diagnosed in this scan. So it is usually associated with any cerebellar deformity or obliterated cisterna magna. So once you look at the brain and you see any cerebellar, so automatically you have to have a detailed spine examination. Also, sometimes vertebral anomalies are associated with other malformations also, like sometimes they are associated with renal malformations, some renal renal agenesis or sacral agenesis. That is, all this, there can be multiple fetal anomalies, and usually this vertebral anomalies are associated with them. So spine has to be examined for all that. So this is a fetal spine. You can see it is clearly seen, the fetal spine. Look for any anomalies, any projections from here, that spinal spina bifida or any protrusions. Here you can see this is the coccyx. This is the spine. That is the iliac bone. Here you can see this is S4, L5. This is the spine. Going to the limbs and extremities, presence of all 4 limbs has to be mentioned. Both hands, both legs has to be documented, all 4 limbs. Now, presence of long bones. Again, you look at the hand, look at both the long bones. All long bones are present, their symmetry, their length, their shape, their alignment, their position, their movement, all should be assessed. Number of fingers and toes should be, if counting is not part of the routine, but if you can see, you have to count. Measurement of one femur is usually sufficient for the measurement of the fetal weight. Unless there is a suspicion of abnormality, sometimes there is length discrepancies. So one leg might be shorter, one limb might be longer. So in that case, you have to measure both the femur length. So here you can see the upper limb with fingers 1, 2, 3, 4, 5, and you look at the joints, whether they are normal. This radius, ulna, here humerus. So all bones has to be seen, all long bones has to be seen, all joints has to be examined, both the limbs, upper limb, both the lower limbs. This is the lower limb. This is the hand, upper limb. This is the feet. You can see one feet is here, both the feet are here. And you look at the toes, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, the joints. So measurement of one femur is sufficient, but if there is a concern, then all bones must be measured. If you see there is a limb look like a fetus which could have a dwarfism. If the bones are short, looking bones, long bones are looking shorter, then all the bones has to be measured and compared to the standardized charts to look for any dwarfism or gigantism, or if there are any bony deform, skeletal dysplasia is there. Suspected deviation from normal at standard examination should prompt a more detailed examination and expert evaluation, and should be counseled for possible skeletal dysplasia or any genetic and non-genetic syndromes. So this is the femur, and you can measure the femur length. Genitalia, although genitalial examination of the fetal genitalia for sex determination is not part of the routine mid-trimester scan. In India, it is not allowed, but you have to look whether it is normal or not. That should be looked for, and you should mention also it is normal external genitalia without mentioning the sex. Placenta. The relationship of the placenta with the internal cervical os should be examined. As I mentioned, whether the placenta is low-lying or it is away from the internal os. If it is low-lying, then preferably transvaginal ultrasound should be done, and the exact where is the placenta, it is covering the os or up to the os, or how much distance away from the os should be documented. If placenta accreta is suspected, then at routine mid-trimester scan, then more detailed evaluation. Placenta accreta or percreta, if you are suspecting, then the best imaging to be done is an MRI. With history of previous 2 or 3 LSCS, then you should go for a higher scanning modality. Abnormal placental findings like presence of any hemorrhage, multiple cyst, or any placental masses like chorioangioma, all this, if it is present, has to be mentioned. This is a placenta. This is how the placenta looks. It is an anterior placenta, normally placed. So the optimum cutoff for the low-lying placenta, there is little evidence, but nowadays we take that placental migration for an anteriorly posterior located placenta, where 5 millimeter and 15.5 millimeter. For an anterior, it is 5 millimeter. Posterior, it is around 15.5 millimeter from the internal os, and using a transvaginal imaging. Anyway, placenta usually migrates. So mid-trimester scan, if you are seeing a low-lying placenta, you should advise them to have a third trimester scan, that is around 32 weeks. You have to look for placental localization. Most of the cases, it will migrate to, the placenta will migrate. So, if the, as I said, if there is a history of previous cesarean, or if there is low anterior placenta, and if you're suspecting, and if there is a high risk of placenta previa or placenta accreta, then you should look at the placenta and look for this findings. Hypoechoic myometrial line below the placenta, if it is not there, large and irregular placental lacunae, interruption of the hyperechoic line between the uterine serosa and the bladder, reduced thickness of the myometrium underlying the placenta and a placental budge. Then that means could be placenta accreta spectrum. Another thing which I told was the vasa previa. Vasa previa means the velamentous. Here what happens is that the fetal vessels, that is the umbilical artery and the vein, they are unprotected and they run through the fetal membranes over or within the 2 centimeter of the internal cervical os. It is found in about 0.5 per 1,000 pregnancies in the general population. Usually the risk factors are twin pregnancy, if they are conceived by ART, or if it is low-lying or bilobe placenta, subsaturate placental lobes, and velamentous cord insertion. If such risk factors are identified, you should have a targeted examination, and if you know that it is vasa previa, then the survival increases. You will plan for an elective cesarean section, but if it is undiagnosed, then there is high chances of perinatal mortality and morbidity. So this can be done using a transvaginal approach with color Doppler imaging has to be done to rule out vasa previa. This is how a vasa previa looks like. The vessels are directly above the os, internal os. The fetal vessels. Here you can see the fetal vessels. So here, this is what happens. The fetal vessels are directly above the os. So in case normal delivery happens, there is high chances of fetal mortality. Last is you have to cervical length. If feasible, ideally you should measure the cervical length in the second trimester scan, because there is, in case if there is a cervical incompetence, usually that mid-trimester abortion is what happens. Mid-trimester cervical insufficiency happens. So if it gets diagnosed, then you can advise them to have a cervical cerclage. If their patients are at high risk, whether there is a previous history of cervical incompetency, ideally they would have got diagnosed. Cervical length would have been done in the first trimester itself, and cervical encirclage would have been done. But if you are clinically also, if there is any suspicion of short cervix, then you have to do a transvaginal ultrasound to see the cervical measurement. So you have to take an additional consent for transvaginal ultrasound, and studies have shown that there is strong correlation between the short transvaginal sonographic cervical length. If it is less than 25 millimeter, especially before 24 weeks, they are found to have preterm birth. So a routine examination of cervical length at mid-trimester scan, at least during your anomaly scan, if it is done, that is good. This is the internal os, this is the cervix, and you measure this internal os, external os, this is the cervical length measure, this is the cervix. So this measurement is taken. Here it is 3.91 centimeter. This measurement from here to here. This is the cervix, this measurement is taken. Here also 4.54 centimeter. Thank you. It is not very easy topic, as in fetal anomaly scan cannot be done by even the normal radiologists find it difficult to do a fetal anomaly scan. But at least you should know the basic things that you should see in a fetal anomaly scan. If when you are reading your reports, if these things are not mentioned, or if it is if there is any abnormality, what all abnormalities and what all structures ideally they should see. And if there are these anomalies, then you should know to refer these patients to the respective, if it's a fetal medicine, if you have a facility for fetal medicine specialists, or if you can refer them to a higher center like a medical college or anywhere, then it should be done. Any
Thank you,
question?
doctor. Thank you so much. We do have a few questions in the chat box, doctor. Meanwhile, I'll also drop the feedback form to get your certificates.
Can we comment on genitals in India? We, as I already told in the this thing, you have to mention the genitalia is normal, but you should not mention the sex. Next question is PPD, yet we are measuring inner to outer table of parietals. In your lecture, you say outer. This is from ISUOG. ISUOG is saying outer. Some people measure from inner to outer, but ISUOG guidelines say that it should be outer to outer.
Any questions, please drop your question in the chat box. The doctor will be able to answer it.
It is a quite elaborate because second trimester scan. That is why I had to go little fast.
Please fill the feedback form to get your certificates. One
I
small
can.
tip, please click on submit button properly so that the certificate will be sent right away to your email. Sometimes our emails might land on spam folders. We are working hard to get over it, but sometimes it happens. So please do check in your spam folders.
Someone has
Is
asked
it-
for femur length measurement. Femur length, is measured from this diaphysis to this diaphysis. Both the diaphysis should be measured. So you keep your transducer in the position 45 to 90 degrees where you get this image on your monitor. So it should be placed at this level. So first you have to identify the fetal limb. Then you look for the femur. Femur is the longest bone of the fetal leg. And then you place it. This should be your image on the screen. Once you get this image, freeze it. And then measure from this diaphysis to this diaphysis. Don't take this spur and this triangular area or anything. And this straight line you measure will give you the femur length. Here also same. From this diaphysis to this diaphysis. Okay.
all of your any of your questions you can just drop in the chat box.
How frequently do Doppler? Doppler is first trimester. We just look for ductus venosus flow, that normal flow or not. And then usually Doppler scans are done as part of your growth scan, which is done around 32 weeks and beyond. If you want to do a Doppler scan, in case of high-risk patients, you can do it at 28 weeks also. But not as a routine 18 to 22 weeks scan, you don't need to do a Doppler.
I think that's it on the question front. Thank you, doctor. Thank you so much for joining this evening and shedding the light on this very particular topic. uh, I would like to add ultrasound in obstetrics is one of the very complicated topic, which and it was also a very big session. Thank you so much. I know we can't pack this in one session, so we plan for more sessions very soon. Now, doctors, please do follow us on social media. I'll also drop our links on social media so that you can follow us on all our social media platforms to stay know about all our upcoming webinars. Thank you so much, doctors.
Thank you.
Now, behalf of Mediversal Academy and all the doctors attendees here, I would say extend a heart warm welcome. Thankful to you for conducting this session. Thank you so much. And thank you all. Thank you for attending the session. I hope you have learnt a great deal. I, for one, agree. The session was great. And I believe everyone stand with it. Thank you so much. Thank you all. Good night. Meanwhile, I'll be here for 2 more minutes. If anyone wants this access to the feedback form, I'll just drop it again. One, yeah, I have dropped the feedback form. Others, Paul, the certificate, if you have submitted the form, the certificate is already sent to your email ID. Please do check in spam folders. Sometimes it will land on in your inbox. If not spam box, one small help is if you find the email in spam box, there is a small button called this mail is not spam. Just click on that. From next time, it will directly come to in your inbox instead of landing it on spam folder. Amir, please held more webinar on cardiology and dermatology also. Yeah, we have lot of webinars planned, but with respect to cardiology, we have a session planned on 25th. Let me also tell you the details 1 second. Yes, we have a webinar on assessment of the right vertical RV on echocardiography by Dr. Mupidi Sarvan. So the session is on 25th. Please do stay active in our groups. You will get the links. Dermatology also. Yes, Dr. Mohammed. Dermatology also we will plan for it. So dropping this feedback form again. So if you have missed somehow in the chat, in the midst of the chat, there you go. Can just click on the form and fill the form to get your certificates. Again, I'm just want to reiterate that certificates will be sent right away once you click the submit button. So I would highly request you to check in spam folder if it is not in inbox. I also want you to click on that not spam folder button so that next time the mail will directly come and land on your inbox. Dr. Ashwini, more cardiac session and gynecology. Uh, Cardiac, gynecology, general medicine, emergency medicine, we keep doing it because these are a few topics which are really vast. So we have so many sessions planned. So mm, if it help, I will also let you know what are our lineup for the month. Uh, we have a new webinar on 23rd, Anemia Demystified, Practical Approach for Clinicians by Dr. Abhishek Singh. On 25th, we have assessment of the right vertical RV on echocardiography, like I said. On 28th, we have from Dr. Raisa, first trimester screening, NT scan and technique interpretation. On 29th, 5th of this month, as tube, tubercular lymphadenopathy, Dr. Sohail Ahmad. Sorry for my pronunciation, but yeah, the session is. And we have also one more session on 30th May. We will be announcing the topic soon. Twinkle want more session from Dr. Navanil and Dr. Alan, please. Yes, sure. Dr. Navanil, we had a session last 18th, right? The two spectrum of nephrology. If anyone wants to come online and share their feedback, I will be able to do that. You can unmute yourself and you can talk or give us the feedback. Great, Twinkle. Thank you. Thank you for attending. I know you're one of our regular. Thank you, Gauravi Shinde. Thank you so much. Please uh, keep attending our webinars, keep getting certificates. Happy learning, keep learning. Any feedback you want to give us, you can come. Any corrections, we can correct ourselves. Gauravi Shinde, you can unmute yourself and you can tell us, or Twinkle, or anyone who wants to talk to us. This is the time where you can. Zoom user, raise your hand. Sir, you can just unmute yourself, you can talk. Thank you. I hope you all enjoyed the session. Oh, see you on the next webinar. Thank you, Yoshua. Thank you so much. Thank you all. Thank you. It was a great session. This kind of engagement is what pushes us to every nook and corner to conduct such webinars. Thank you so much. Thank you all. Good night.